esteemed doctors, genetic counselors, and esteemed guests joining us today. On behalf of Unigenome, a division of Unipath Specialty Laboratories, and the Genetic Clinic, I extend my heartfelt gratitude for your presence in today's webinar on Decoding Alpha Thalassemia, Insights for Clinical Practice. I am Dr. Monica Darjeev, Scientific Marketing Head at Unigenome, and it is my privilege to be your moderator for this academic session. Alpha thalassemia continues to remain an under-recognized yet clinically significant hemoglobinopathy, especially in the context of antenatal screening, fetal medicine, and genetic counseling, and even complex anemia evaluations. Through today's session, we aim to simplify the clinical understanding, molecular basis, diagnostic approach, and the interpretation of alpha thalassemia cases. Before we begin, I would quickly share a few housekeeping points. This session is being conducted in listen-only mode for the participants to ensure smooth audio quality. We encourage you to post your questions in the Q&A chat box during the session. We will be addressing the questions during the dedicated Q&A segment towards the end of the webinar. Kindly stay with us till the conclusion as the panel discussions promises a highly practical and case-oriented insight. Now it is my honor to introduce our respected chief guest for today's session, Dr. Ramachandran Shaji, Professor, Department of Hematology and Adjunct Scientist at the Center of Stem Cell Research at the prestigious Christian Medical College, Vellore. His academic journey is truly global. After completing his PhD in biomedical sciences at CMC Vellore, he spent several years in the United States, where he pursued his postdoctoral fellowship at two world-renowned institutions, St. Jude Children's Research Hospital and University of Chicago. Today, Dr. Shaji, sir, is recognized for his clinical and significant contributions to molecular diagnosis of hematology diseases. His research is at the forefront of the field, particularly in disease modeling and the development of lentiviral gene therapy, innovations that are actively shaping the future of how we manage complex blood disorders. Dr. Shaji, sir, we are incredibly honored to have you with us today. I would request you to kindly address the audience with your opening remarks and set the context with an introduction to alpha thalassemia. Thank you.
Thank you very much for the introduction. I welcome the audience to this webinar on understanding alpha thalassemia, the basics, diagnosis, and also we want to hear from the clinicians how this most common genetic disease is treated. My responsibility today is to give a short introduction on alpha thalassemia. Although the slide says molecular diagnosis of alpha thalassemia, in the next 3 to 4 slides, I'm going to give you the basics on alpha thalassemia, molecular basis, and few techniques. And subsequently, the speakers will take us through the new technologies that have been used for the molecular diagnosis of alpha thalassemia, and also the treatment options. And in this presentation, the first part, what I want to show you is to how complicated alpha thalassemia is. Because we have 4 copies of alpha globin genes, we have variety of genetic conditions in alpha thalassemia. The two symptomatically severe forms are called HBH disease, and also the most severe form, which is HB Bart's hydrops fetalis. In HBH disease, 3 genes are inactive, and HB Bart's, all the 4 alpha globins are inactive. HPH disease patients present young children with severe anemia, and the laboratory test gives indications for alpha thalassemia. Then we do series of tests and do the diagnosis. But HP BARDS goes undetected. It is because there's a disease that causes intrauterine death. Said most of the patients with HP BARDS are not born at all. So the clinical presentation of the alpha thalassemia depends on the number of alpha globins are deleted or inactive. This slide shows that there's one in chromosome 16 how alpha globin 2 and alpha globin A, alpha globin 1 genes are arranged. And the other chromosome also has another copy of HBA2 and HBA1, totaling 4 alpha globin genes there. And if you look at the mutations, and 85% of the mutations are caused by deletions, copy number variations. And 15% of mutations are caused by point mutations. And there's mechanisms why those deletions are more common than point mutations there. So therefore, a set of methods are being used for identifying deletions and point mutations separately. In the lab side, when the patient's samples arrive for undiagnosed anemia, we have to look at the CBC values very carefully, and we have to look at the clinical phenotypes very carefully. And the most common confounding diagnosis will be iron deficiency anemia. However, looking at the CBC values, including RDW and doing tests for ferritin and transferrin saturation tests, and we may be able to do some call on the patient's diagnosis towards alpha thalassemia. After getting an idea that the patient may have alpha thalassemia, a variety of techniques can be used, and there's gap PCR to identify the common deletions. Now we have MLPA for identifying deletions, and then for point mutations, we can use these methods of Sanger sequencing or NGS. So there has to be a hierarchy of tests to be used because the deletions are more common. Gap PCR and MLPA should be used first, then sequencing can be used for detecting the point mutations there. And MLPA is very efficient. The point mutations can be detected, deletions can be detected very efficiently. And we had reported earlier that there are common deletions in the alpha globin cluster, including the South African deletion. And these deletions can be detected using gap PCR first. However, when you see a possibility of other deletions, looking at the CBC values, we can do MLPA and look for rare deletions. We also have developed a method called gene dosage PCR, which is easy to do, and alpha globin copy numbers can be accurately determined by looking at the peak intensity of these genes, and it can be normalized with the peak intensities obtained from a control sample, and the accurate diagnosis can be determined there. As I said, if there's non-deletional, there's a point mutations where options of Sanger sequencing could be looking at the CBC values and do tests to rule out iron deficiency anemia. And if there is an indication still for alpha thalassemia, then do gap PCRs and then move forward to do other copy number variation tests, including MLPA. And still alpha thalassemia is suspected, we should do NGS and check whether point mutations occur. Sanger sequencing could also be used. Okay, I will stop here. I will ask the next speaker to take it over from here.
Thank you very much for your kind words, sir. Now I'll introduce our next speaker. Our speaker for today's session on molecular basis of alpha thalassemia and genetic counseling is none other than Dr. Seema Thakur Madam, who is a distinct speaker. She brings her incredible 25 years of specialized experience in genetic and genomic counseling. She is currently serving as the director of genetic clinic in Dwarka and holds senior positions at Fortis Hospital, Shalimar Bagh, and Rainbow Children Hospital in Delhi. Ma'am's academic pedigree is equally distinguished, holding an MS in obstetrics and gynecology, DM in medical genetics, and fellowship of Indian College of Obstetrics and Gynecology. Her contributions to medical literatures are vast, with over 70 publications to her name, including high impact research in prestigious journals like Nature Genetics and American Journal of Medical Genetics. A recognized leader in the medical community, she is the current vice president of the Delhi Gynecological Forum, Dwarka. Her dedication has been honored with numerous accolades, including the Distinguished Medical Luminary Award in 2021 and most recently, the Nari Shakti Award by IMA Dwarka in 2026. Please join me in welcoming a renowned expert, academician, and researcher, Dr. Seema Thakur, ma'am. Over to you, ma'am.
You are muted, ma'am. Ma'am, you are muted.
Yeah. So thank you, Monica, for such a kind and elaborate introduction. Can you see my screen?
Yes, ma'am, we can see them.
Yeah. So it's the previous Dr. Shaji has already introduced the topic to you. So my job has become much, much easier because alpha thalassemia, as you all know, is a complex molecular genetics. And so we need to revise again, probably through my slides again. So I'll be discussing about the structure and function of alpha globin genes, molecular basis and inheritance, then correlate the number and the type of the alpha globin genes, then antenatal and the obstetric significance, and the practical approach for the practicing fetal medicine and obstetric consultants, so as to include this in the workup of the microcytic hypochromic anemia. So this topic matters because frequently identified during the antenatal evaluation of the microcytic anemia. This is an important cause of carrier status in populations from Asia, India, Southeast Asia, then Middle East, Africa, and Mediterranean region. And severe fetal forms can lead to hydrops fetalis, stillbirth, maternal complications, and early diagnosis will enable the partner testing, the carrier analysis, then the prenatal testing. So the prevalence initially estimated was using the hemoglobin BART in the cord blood, but this was underestimated. So the molecular testing has provided more accurate data and increasing global prevalence due to the population migration. In North America, there is a low prevalence 0.03 to 0.06 per 100,000, whereas there is a high frequency of alpha 3.7 allele 0.30 to 0.40 in equatorial region like Nigeria, Kenya. Double gene deletions are rare here. In India, there is high allele frequency in tribal population of Andhra, lower in other groups, and double deletions are fortunately rare in our part because the double deletions predispose us for the recurrent hydrops fetalis, the one which leads to the fetal anemia and the ultimate fatality. In Southeast Asia, there is a very high prevalence of the common deletions, and this is a significant public health burden in the Southeast Asia. The hemoglobin BART is 0.5 to 5 per 1,000 births. The hemoglobin H is 4 to 20 per 1,000 births. So this is a significant public health burden in the Southeast Asia. So the normal hemoglobin is the oxygen carrying protein in the blood, and adult hemoglobin is composed of 2 alpha and 2 beta globin genes. Alpha gene production is therefore essential for the normal hemoglobin assembly. Reduced alpha globin chain production will lead to the imbalanced globin synthesis and thus will lead to the ineffective erythropoiesis. So the common types of thalassemia, alpha and beta, And alpha thalassemia is an inherited autosomal recessive disorder caused by the reduced or the absent production of the alpha globin chain, and it results in the decreased hemoglobin formation, microcytosis and anemia, and disease severity ranges from asymptomatic to silent carrier to hemoglobin H to the hydrops fetalis and a fatal disease. So alpha thalassemia, as Dr. Shaji has already highlighted, that the peculiarity of the alpha globin gene is that normally we have 2 copies of any gene, but in this case we have 4 copies, 2 on each chromosome 16, and we have these genes are located on chromosome 16, and each person has got 4 globin gene. So the normal will be 4 globin, silent carrier, only 1 gene deleted. This slide is actually very important. If you understand this, half of the job is done for understanding the alpha thalassemia. So the minor will have 2 genes deleted. This can be on the cis or it can be on the trans. So this is what this type of, the minor matters for the hydrops fetalis. Fortunately, we have less of this in our country. In hemoglobin H disease, the 3 alpha genes are non-functional, whereas the Bart's hydrops fetalis, all the 4 alpha genes are knocked out. So the severity increases as per the alpha globin number abnormality. So the normal is 4 genes, no disease, and 1 gene deleted like a silent carrier. They are silent carrier asymptomatic. Alpha thalassemia trait is also asymptomatic like any other trait. Hemoglobin H can have a variable clinical severity, including asymptomatic to anemia, splenomegaly, the hydrops fetalis, the one which is then in addition to the decreased production, we also have alpha globin chain structural variant, which keeps coming us because we are all doing the HPLC as a universal for prevention of beta thalassemia, because beta thalassemia is quite common in our country. 10,000 children of beta thalassemia are born each year in our country. So in those HPLC, we come across these alpha chain variants, that is the Q India, hemoglobin J Merit, hemoglobin J Paris, Toronto. So the genes is, the alpha globin is hemoglobin A1 and A2, and usually it is caused by the deletions, less commonly the non-deletion variants. The deletion and the non-deletion, they reduce the alpha globin synthesis, causing the excess of the alpha globin chains, and these abnormal alpha globin chains, they form unstable hemoglobin such as hemoglobin H and hemoglobin Bart, which carry oxygen poorly and damage the red cells. So the deletional alpha thalassemia, that is the loss of 1 or more alpha globin genes, and non-deletion, that is because of the point mutation. Non-deletion often produce alpha globin gene more severely than often reduce more severely compared to the deletion one. So therefore the genotype interpretation must consider not only the number, but also the type of the mutations. So the clinical spectrum, as we know, there are 4 normal genes, 3 functional is a silent carrier, 2 functional is alpha thalassemia trait, only one functional is H, and Bart is so silent carrier, only 1 gene affected, alpha thalassemia trait, 2 genes affected, and hemoglobin H gene disease, which is actually clinically relevant. So 3 genes are affected. So they are usually caused by the alteration of the 3 of the 4 alpha globin gene alleles, and they produce hemoglobin H, and abnormal hemoglobin, which is formed by the excess beta chains. Clinical features include mild to moderate anemia, jaundice, and hepatosplenomegaly. Presentation often appears in early childhood, but patients usually survive into the adulthood. So the hydrops fetalis, which is caused by the alteration of the deletion of all 4 alpha globin alleles, and this leads to the hemoglobin Bart formation and absence of the normal alpha globin gene production. This is associated with the severe fetal anemia, hydrops fetalis, and death in utero. So in alpha thalassemia, we have in utero presentation, in contrast to the beta thalassemia, where usually after 4 or 5 of the birth, when the hemoglobin adult is not produced, then only it manifests, whereas the alpha globin gene is required in the production of the fetal hemoglobin. So this manifests at the so that there are 2 basic alpha globin chain which will clinically significant. One is the hemoglobin Bart syndrome, that is the hydrops fetalis, and the hemoglobin H. So the Bart is the most severe, and all the affected fetuses will be either delivered stillborn or at 30 to 40 weeks gestation, or die soon after birth. So the main clinical features are generalized edema, pleural and pericardial effusion as a result of the congestive heart failure, which is caused because of the severe anemia. And these red blood cells with the hemoglobin BART, which is gamma 4, has got extremely high oxygen affinity, so they are incapable of effective oxygen delivery. So the extramedullary hematopoiesis, the marked hepatosplenomegaly, and a massive placenta, these are the common manifestations. Deficient brain growth, hydrocephalus, even the cardiac abnormalities has been reported. A very small number of newborns survive following the intrauterine transfusions and repeated blood transfusions after birth. Even the maternal complications can occur during the alpha thalassemia. So they are common like preeclampsia, polyhydramnios, oligohydramnios, and premature delivery. So the hemoglobin BART is the severe fetal anemia and leading to the hydrops fetalis. So what is the pathophysiology? In the absence of the alpha globin chains, the gamma globin chains, they form hemoglobin BART, that is the gamma 4, which has got very high oxygen affinity. So the normal tissue, the RBCs will deliver oxygen. But in cases of the hemoglobin BART, the oxygen will not be delivered to the, so there is an ineffective oxygen delivery to the fetal tissue despite apparently adequate hemoglobin levels. So this tissue hypoxia will trigger compensatory erythropoiesis and the cardiac strain. And the progressive anemia will lead to high output cardiac failure, and this will result in the hydrops fetalis, so which is a terminal stage characterized by generalized edema, ascites, pleural effusion, pericardial effusion. So this is the pathophysiology. Like we have anemia, tissue hypoxia, which will lead to extramedullary hematopoiesis, heart failure, interferes with the organogenesis, massively enlarged placenta. So just a few words about how the hemoglobin. So we have the alpha-like chains like the zeta and the alpha, and the beta globin-like genes like the epsilon and the gamma and the beta genes. So these are the So in the first week of embryonic life, we have Gower 1, Gower 2, Portland 1. By the 12th week, the embryonic hemoglobin is replaced by the hemoglobin F. And that becomes the majority of the hemoglobin in the fetal life, 70 to 80%. So that's why when the alpha gene is lacking, this will not be produced. So the defect in the alpha globin gene affecting the formation of both fetal and the adult hemoglobin, and unlike beta thalassemia, this is an in utero disease. So here we can see that in normal fetal development, initial hemoglobin synthesis is hemoglobin Gower 1, that is the zeta 2 epsilon 2, and these will be there will be a transition at 5 to 7 weeks where this will be replaced by the alpha globin chains, and then the normal fetal hemoglobin, that is the alpha 2 gamma 2 predominates. Whereas in cases of the alpha thalassemia major, the initial part is okay till 5 weeks, but the switch fails due to the absence of the alpha globin gene production. So the problem starts as early as the 7 weeks, and that leads to abnormal hemoglobins which form the hemoglobin BART. And this leads to ineffective oxygen delivery because of the high oxygen affinity of the alpha globin, the hemoglobin BART, and thus leads to the early onset fetal anemia, and then thus the cardiac failure and hydrops fetalis. So the cardiac feature, the chronic fetal anemia will lead to increased cardiac output and cardiac failure, and this manifests as ascites, pleural effusion, that is the pericardial effusion, skin edema. Even there will be associated placentomegaly. So how a clinician who deals with the fetal ultrasound, so how they will suspect, because clinically the major issue in why we are not recognizing these cases is because we are not, there has to be a clinical index of suspicion. So whenever there is a case of hydrops fetalis, one must check that whether there is associated fetal anemia, because if there is associated fetal anemia, that will give us a clue as an insight that we need to check the parents whether there is a microcytosis, whether there is a HPLC not showing beta thalassemia, or whether there is a, the molecular genetic testing, and this will allow us to guide the timing of the invasive procedures, transfusion, and maybe. So diagnosis of fetal anemia, as we all know, has now become non-invasive by the MCA Doppler. And this is the landmark paper which was published in NEJM by Mari et al. In 2006. That is the Doppler ultrasound versus amniocentesis to predict the fetal anemia. So this is a non-invasive method, and this has proved so much successful for the non-invasive prenatal, non-invasive diagnosis of the fetal anemia that we are doing so much in the RH isoimmunization. The same MCA Doppler studies can be utilized in the detection of the fetal anemia, which is caused by the alpha globin gene, alpha thalassemia. So, and if we detect the alpha thalassemia, anemia due to alpha thalassemia, then intrauterine transfusion is the mode of the treatment, and that can be done, and the fetus can be salvaged, and they would require as early as 20. So this is the intrauterine transfusion video, which I have taken from my So you can see here the needle going and the blood, the jet of the blood you can see. So this is the case of not the alpha thalassemia. This is a case of RHM, but this is the same intrauterine transfusion can be done. And once we can carry forward the pregnancy and the child is delivered, the child will require the same regular transfusion like beta thalassemia. So currently there are in utero hematopoietic stem cells transfusion also which has been reported for the alpha thalassemia major or the severe combined immunodeficiency, but the engraftment rates are not very good. So this is yet the in utero hematopoietic stem cell therapy is experimental only. So this is I have taken from this advances in the management of alpha thalassemia major reasons to be optimistic, but till now this is still in the experimental stage only. So emerging molecular therapy, which can be like a gene therapy, but they are still experimental only. So now with the clinical background, now how do we do the test if we are suspecting that the CBC is showing microcytosis, there is no HPLC is normal and A2 is less, then we, as Dr. Shaji has already highlighted, that the major component is the deletion analysis. So we can do by the gap PCR or we can do by the MLPA. And if the MLPA is normal, then the sequencing of the hemoglobin A1 and A2, or even these days, even the NGS can also be utilized for the alpha globin gene point mutation analysis. Then there is another area which is about 40 kb upstream to the alpha hemoglobin A1 and A2. Even deletion in this area has also been reported to be associated with, although they are quite uncommon, but they have been reported to be. So the whereas this locus, which is upstream to the A1 and A2, that accounts for less than 1%, and the point mutation analysis accounts for 15%. The deletions is about 85%. So the majority of the mutations in alpha thalassemia is deletion and duplication, in contrast to the beta globin gene mutations, where there are mainly the point mutation, deletions account for minority. So the genotype phenotype, as we just discussed, that it is mainly the large deletion of the both A1 and A2 on both the chromosomes. We can see here 4 minus. Rarely an individual with hemoglobin BART will have a non-deletion variant. That is the non-deletion, this is the denoted like this. And hemoglobin H disease, this is usually caused by the deletion of the 3 alpha globin gene, like we can see a 1, 2, and 3. Or another non-deletion like this 2 and the other one 3. But this can also be caused in the individual who are homozygous for hemoglobin A2 pathogenic variants like this, and may have hemoglobin H disease, and rarely this can be a compound heterozygosity for the MCSR2 deletion and an additional alpha globin. So these are little complex. So generally in practice, we see whether the deletions are there. If we don't find the deletion, then we move on to either the sequencing or the. So the inheritance is, of course, is the autosomal recessive disorder, and so the risk of recurrence of if both the partners are carrier, then this is 25%. And it is the cis which matters most for the hemoglobin BART. Cis means both the deletions are on the same chromosome, whereas it seems that in our country we are mostly having this because or maybe we are not detecting hydrops much due to the alpha thalassemia. Few cases. So as I just discussed, that because we are doing HPLC universally as a part of the prevention of beta thalassemia major. So this was a primary gravida at 26 weeks, and her hemoglobin A was 66.6 and A2 is 4.2, so this is not less, and there was a peak of at 23.5%. So after the HPLC, the hemoglobin electrophoresis was done at alkaline pH, and that showed a fast moving band along with a prominent band in hemoglobin A, and there was a acidic pH, a band in the hemoglobin A region, and this suggested that so the husband's HPLC was done. So whenever we come across one partner having problem in the HPLC, it's mandatory to do the husband's HPLC just to exclude that whether he is a thal trait. So we performed the HPLC for the husband, which was normal, and wife, we confirmed this hemoglobin J merit by the molecular testing and also the beta globin gene sequencing. Because the HPLC was of the husband was normal, the beta globin gene sequencing was normal, so we didn't perform any prenatal testing. So what is hemoglobin J? These are the fast-moving hemoglobins. They are a heterogeneous group of rare hemoglobin variants which belong to the hemoglobin J family. It can be J Meerut, J Bangkok, Baltimore. So hemoglobin J Meerut is a alpha globin chain derived, and Blackwell et al. First reported this from the two sisters from Meerut, India, and that's why this is called hemoglobin J Meerut. And a majority of these are clinically silent, and they can be detected during family or the antenatal screening by the alkaline gel electrophoresis. So partner who carries a beta thalassemia and partner who carries the alpha thalassemia, so there will be no particular problem in this particular case that we just so this is a case of the two boys with the intellectual disability. In the case one, she had come to us after this when this child was born, and she wanted the prenatal diagnosis for the counseling for the next child. And this is a very old case, and maybe 2009 or 10. So because there was a hypoxic changes in the MRI, so we suspected that this could be due to the birth asphyxia because there was associated, and we assured them of the low risk of recurrence. And then the next case, when the child was born, so that child had a CBC which showed microcytosis, and serum iron and TIBC was normal. HPLC for hemoglobin was normal with a slightly raised hemoglobin F. And hemoglobin electrophoresis was then done, and which showed 3 bands: faint band in the region of the hemoglobin A2, prominent band in the hemoglobin A, and a fast moving band which was suggestive of the hemoglobin H. So the staining for the red blood was done using the brilliant crescile blue, and which showed that there are hemoglobin H inclusions in 25% of the cells examined. This is the peripheral smear, and which was stained by the brilliant crescile blue. And this suggested the diagnosis of the alpha thalassemia, and diagnosis of ATRX was then suspected, and the mutation studies were done. This we published in 2011, ATRX syndrome in 2 siblings with a novel mutation in the exon 31. So we have to detect microcytosis, anemia, and check the ferritin and evaluate the iron deficiency, then do the HPLC, and if microcytosis persists with the normal electrophoresis, we need to do the alpha globin gene and analysis and do the molecular testing. If mother is a carrier, then we need to test the partner, and if both partner are carrier, like any autosomal recessive disease, we need to do the prenatal testing. This I have taken from the same alpha thalassemia paper by McKenzie. That is the pregnant women for high risk. This is an algorithm which we can say from high risk pregnancy geographic ancestry, the Southeast Asia, the Chinese, Asian. And so at first visit, one must do the CBC, ferritin, and hemoglobin electrophoresis with A2 quantification. And if the ferritin is less than 30, then we do the iron supplementation. Otherwise, these women have a risk of the high iron overload like any thalassemia trait. So if we are doing iron supplementation, we must check the ferritin. Then if CBC shows MCV less than 80 or MCH less than 2 and hemoglobin A2 is less than 3.5%, then alpha globin gene DNA PCR testing. And if she is positive, then father's evaluation by CBC, electrophoresis. And if the both partners are positive for alpha thalassemia trait, then we need to do the prenatal testing and ultrasound every weeks, or we can do the by the CVS. So there can be a non-invasive testing, or there could be a CVS testing. And if the fetus is positive for the alpha thalassemia major, then the in utero hematopoietic stem cell, the intrauterine transfusion. This is the chart for the in utero trial which they are doing. So that's why they have said. Otherwise, it is mainly the intrauterine transfusion which is the treatment of choice for the hemoglobin Bart fetalis. And so finally to conclude, alpha thalassemia is a common inherited hemoglobin disorder with major reproductive relevance. Disease severity is by the number and the type of the affected alpha globin genes. Normal hemoglobin electrophoresis does not exclude the alpha thalassemia, and it is inter-partner testing, molecular diagnosis, they are the central to the perinatal risk assessment. And severe fetal disease can endanger both mother and the fetus, and intrauterine transfusion is the mode of the treatment for the intrauterine alpha thalassemia. And if the child survives, then the hypertransfusion like beta thalassemia will be indicated. So research by the in utero stem cell therapy is not as yet promising, but yes, probably in the future. So thank you, everyone.
Thank you, Dr. Seema ma'am, for such an insightful and clinically relevant session. I must say your ability to simplify the molecular basis of alpha thalassemia and connect it with the practical clinical decision making and the insights for genetic counseling are truly valuable.
Thank you, Monica.
Moving on, I'll present the slide for our next panel discussion. So it is my distinct honor to introduce the chairperson for the panel discussion. We are privileged to have with us Dr. Neeraj Arora, sir. Sir is currently serving as the Director of Molecular Biology at Unipath Specialty Laboratory in Ahmedabad. His academic journey is truly exceptional, holding an MD in pathology, followed by 2 specialized postdoctoral fellowships, one in
I think Dr. Monica got locked out.
Yeah.
She might join.
Yeah.
Maybe.
Oh.
I think we can start.
Yeah, I think she has joined back very quickly. Yeah. Dr. Monica?
Yes, ma'am, I lost the connection, I think.
Okay,
I'm just
no
sharing
problem,
this.
but quickly you
Yeah, you were able to log in quickly.
Yeah, you managed very quickly.
So this unique combination of expertise makes him one of the few specialists capable of interpreting the complexities of blood disorders through the lens of genetic precision. Beyond the laboratory expertise, Dr. Arora sir is pivotal figure in national scientific community. He is the Secretary of Molecular Pathology Association of India. He works tirelessly to standardize molecular testing across the country with 50 plus peer-reviewed publications in prestigious journals. His contribution to the field of genomics and oncology is recognized both nationally as well as internationally. Sir, thank you for joining us and supporting this educational initiative. Moving on, I would like to introduce our next panelist, Dr. Ishan Dabare, a consultant clinical geneticist with an extensive background of academics, MD in pediatrics, DRNB in medical genetics from Sir Gangaram Hospital. He currently serves as the consultant clinical geneticist at Unigenome and Arogya Vansh Genetic and Hematology Specialty Clinic in Gandhinagar, with specialized expertise in neuromuscular disorders, in error of metabolism and skeletal dysplasia. Dr. Ishan brings a vital clinical perspective to our discussion today. We also have Dr. Seema Thakur continuing as the panelist. Moving on, I would like to introduce Dr. Ekta Jajodia. Dr. Ekta ma'am is a consultant molecular pathologist at Unigenome. She brings an exceptional academic and research background to this panel. She completed her postdoctoral training in molecular hematology at the prestigious CMC Vellore and has authored over 35 research publications. She's deeply passionate about hereditary blood disorders with specific focus on thalassemias, hemoglobinopathies, and iron-related disorders. Today, she'll be guiding us through a case-based discussion titled Simplifying Alpha Thalassemia. Please welcome Dr. Ekta Jajodia as she takes the floor to present the case and moderate the discussion. Thank you.
Hi, good evening,
Dr.
everyone.
Yukta, ma'am, you can just start presenting.
Dr. Monica, I'm not able to share. Yeah, 1 second.
Yeah, your screen is visible now.
Yeah, is it visible now?
Yes.
Yeah. So good evening, everyone. Today our panelists.
Your presentation, ma'am, excuse me, your presentation is still not visible. It's the computer screen that we can see.
You
Yeah,
can
it's
see
visible now. Thank you.
Visible now?
Yeah,
Yes,
full
ma'am.
screen, please.
Yeah. So good evening, everyone. Today we'll be presenting 2 cases, and our panelists will be Dr. Ishan and Dr. Seema, ma'am. And both the cases will be dealing with the alpha thalassemia. One will be dealing with the deletional type of alpha thalassemia, and the other will be non-deletional. So we'll see a combination of both kinds, how they present in clinically and in lab, how do we approach the cases. So the case one is she's a 30-year-old female with microcytic hypochromic anemia. There was no history of blood transfusion. There was no family history of thalassemia or any such anemia background. There was no such family history as well. She gave a very significant history of 2 previous pregnancy loss. She came to the hematologist for actually anemia workup, and the hematologist did a battery of tests along with hemoglobin HPLC. Hemoglobin HPLC showed HbA, the adult hemoglobin of 84%, HbA2 of 0.7%, and HbH of 15%. So hemoglobin HPLC SBC shows a decreased HbA2 level. Usually the HbA2 level should be around 2.5 to 3.5%, but this was severely decreased to 0.7%. And there was also presence of HbH. So at this stage, what are your top differentials, Dr. Seema, ma'am?
Yeah, so the first would be, of course, we live in iron deficiency belt. So first is again the iron, but here in context of this is the high possibility of alpha thalassemia.
Okay.
Because of the microcytosis, the hemoglobin H, then decreased hemoglobin 2. This is the only diagnosis here. It comes to my mind is the alpha thalassemia only.
Yes, right. So iron deficiency can be seen, but with the CBC and everything else, with HbH.
Hemoglobin H, yeah.
Yes.
It will not.
So alpha thalassemia is quite evident here.
Yes.
So again, Dr. Seema, ma'am, what features or hematological patterns make you suspect alpha thalassemia specifically in this case?
It is basically microcytic hypochromic anemia with raised normal iron studies. And basically, I could see the hemoglobin H. So that was the main clue to their diagnosis, and in the presence of microcytic hypochromic anemia. And the normal hemoglobin A2 and the hemoglobin F on the electrophoresis. Apart from that, if we do the peripheral smear, we will get to see the target cells and isopoikilocytosis on the peripheral smear. And the supravital brilliant crescile blue will give us about the clue about the hemoglobin H disease percentage, or there can be a family history or ethnicity associated with the thalassemia prevalence. So
Is correct. A lot of times what we see is we miss out on HbH inclusions on supravital stain. I mean, we miss out on doing the stain itself. So this is a
yes,
very simple and very easy and very cost-effective test to be done whenever a HbH disease is suspected in a lab.
yeah,
So
and
the
the
key point,
electrophoresis also. It's not only the HPLC, it is also the electrophoresis which complement each other, because the on the electrophoresis, usually you will get the H bands, which is the faster band. So
yes, correct. So microcytosis with normal HbA2 should strongly raise suspicion of alpha thalassemia. In this case, even the A2 was not normal, it was significantly reduced.
yeah.
So this is for Dr. Ishan. How reliable is hemoglobin electrophoresis or HPLC in alpha thalassemia?
So, first of all, good evening and thank you for inviting me. So we all, do HPLC very regularly for looking at beta thalassemia. So that has been the standard. But in order to diagnose or to suspect alpha thalassemia by means of HPLC, one has to have a little higher index of suspicion and has to keep certain points in mind. So first point is that normal HbA2 levels can be seen in alpha thalassemia. It is because silent carriers and even alpha thal trait, they will not cause significant decrease in the HbA2 level, and it can be passed off as a normal HPLC. Second point is that, as Seema ma'am rightly said, that if HbA2 level is low, the most common reason is not the alpha thalassemia, it's actually iron deficiency anemia. So firstly, we have to check for the iron level, ferritin level, and then correct the iron and then repeat and see whether it is still low or not. Third thing we have to note is that the HbA2 is made up of 2 alpha chains and 2 delta chains. So if there is a delta mutation still, it can lead to low HbA2 levels. So that thing also has to be kept in mind. And fourth thing is that in addition to low HbA2, which is seen in alpha thalassemia, if patient has HbH, so in the HPLC, the HbH gets eluted very early on. So if the lab has not got or is not keeping suspicion of alpha thalassemia, it might miss out on reporting this. So from the lab perspective also, it is important that the lab picks up the early HbH elution and report it accordingly, so that with a combination of HbH and a low HbA2, then we can suspect a alpha thalassemia. So this is about the HPLC. HPLC will only give you suspicion of alpha thalassemia. Finally, if you want to confirm alpha thalassemia, it is always by means of molecular testing. And DNA analysis, it remains the gold standard.
Thank you, Dr. Ishan. So moving on, so what molecular approach, Dr. Seema ma'am, would you take in such a case?
Yeah, so because the alpha thalassemia, 85% mutations are deletional type. So the first test of choice would be the gap PCR or the MLPA. Currently, we are doing mainly the MLPA because the gap PCR will detect deletions which are the known deletions like 3.7, 4.2, and Southeast Asians, Mediterranean. So only the known deletions. But MLPA will cover the rare, the large, as well as the known and unknown both deletions. So this is the test of choice in the current time. And if we are suspecting strongly that this is alpha thalassemia, then we can do the alpha globin gene sequencing, or we can move on to the NGS for the non-deletional alpha thalassemia variants. So a combined strategy should be like, first the CBC, that is the complete blood count, plus HPLC or hemoglobin electrophoresis, then gap PCR for common deletions, and MLPA for the or sequencing for the unresolved cases.
Okay, so the key message would be that a deletion first approach remains the most practical and cost-effective strategy, and that should be done by alpha MLPA, although gap PCR can also be used, but as ma'am said that gap PCR can also look at only the common ones. So MLP more preferred choice here. And NGS to be reserved only for unresolved or complex cases, because 85 to 90% of the alpha thalassemias are because of the deletions, and NGS are not very good in picking up the CNVs in alpha genes. So a little about what is MLPA. So this is called multiplex ligation dependent probe amplification. This test is done to look for very large deletions within the alpha globin gene cluster. When I say alpha globin gene cluster, it includes both alpha 1, alpha 2, HbA1 and A2 genes, along with the other neighboring genes like zeta gene and the epsilon gene. So all those genes will also be taken into account. So it includes there are multiple probes which targets all those genes, and deletions can be detected if the probe is not attaching. Then we say that this part of this region of the cluster is deleted. So this is how an MLPA chromatogram looks like. So we expect that all these probes, on the right side, there are around 9 reference probes. So that needs to be always attached, because only when the reference probes are attached, we say that the test has been correctly working. And the other genes are all related to alpha globin gene cluster. And we expect that in a normal situation, all these probes the yellow color ones, should lie in the ratio of 1. So anything below 1, if it is 0.5, we will say it is an heterozygous deletion. If it is 0, we will say it is an homozygous deletion. And alternatively, if it is 1.5, we will say it is a multiplication. So in this case, we had done alpha MLPA and we saw that there was 3 alpha globin gene deletion. We can see the picture here. Some probes lies in the 0.5 region, while some probes are lying in the 0 region. So when we conclude the diagnosis, we do the analysis, we see that one allele was having 2 gene deletion corresponding to the Southeast Asian type, and the other allele was having a 1 alpha gene deletion corresponding to the most common one, alpha 3.7. So in total, 3 alpha globin genes were deleted, and this genotype is consistent with the HPH disease phenotype. So for Dr. Seema, how does a patient with HPH disease usually present?
Yeah, so they will be mainly presenting with the anemia, and that will be microcytic hypochromic hemolytic anemia. And some people can even be the asymptomatic as well. Like in this patient, she didn't have much of the issues other than, mild anemia. So the severity will range from mild to moderate with variable transfusion requirements. And the hemoglobin tetramers, which are formed, that is the excess beta globin gene because of the beta 4 tetramers. They form the unstable tetramers, which is detectable on the HPLC or the electrophoresis. Non-deletional HBH disease is usually more severe, and like the range is quite large, like from the asymptomatic to the mildly to even the transfusion dependent. So we need to have a high index of suspicion by looking carefully at the CBC, the HPLC, and if the beta globin gene is normal, then we should do the further workup for the alpha globin gene.
Okay, ma'am. So for Dr. Ishan, which genotype combinations commonly produce the HPH disease? So is it only the 3 alpha globin gene deletion that causes HPH, or there is more to this?
So we have to understand what is HBH. HBH is nothing but beta 4 tetramers. And why would beta 4 tetramers occur in the first place? Because there is an imbalance between the alpha production and the beta production. In this case, the alpha production is much lesser than the beta production, and the excess beta chains, they end up forming the tetramers known as the HBH. Now, that means any condition that will lead to excess of beta production as compared to the alpha should produce HBH. So most commonly, since alpha thalassemia is caused because of the deletional variety, the most common cause of the HBH disease would be a deletional type of alpha thalassemia, where there are 3 out of the 4 alpha globin genes that are deleted, and this will cause a severe imbalance between the alpha and beta. However, that is not the only mechanism by which HBH disease can occur. It can occur in non-deletional HBH disease also, non-deletional alpha thalassemia also, where there is a point mutation in the alpha globin gene, which renders the alpha globin chain ineffective and thereby again leading to the imbalance. So a homozygous point mutation in the alpha globin gene can also lead to a HBH disease, and also a combination where one allele, one copy of the gene is having a point mutation and the other copy is having a deletion. That situation can also produce a alpha HBH disease. Now, the important thing to note is that like ma'am also said, that the point mutation or the non-deletional type of alpha thalassemia tends to be more severe than the deletional type of it.
Okay, Dr. Ishan. So, since the history of repeated pregnancy loss was given, what more would you like to know? Would you test the spouse in this case, Dr. Seema?
Yes, because she is like, I would like to know what type of pregnancy loss she was having. Was she having the first trimester losses, or is she having the second trimester having going to the hydrops fetalis? So that will give me, the index of suspicion that yes, she is probably having the alpha thalassemia, and that's why leading all those pregnancies. So now, because we already know that she has got 3 genes deleted, so the spouse testing is essential, and we will do again the CBC, the same combinations, that the CBC, HPLC, or electrophoresis. And if he is showing microcytosis and the electrophoresis is normal, then we can move on to the molecular testing for the deletions first, and followed by the non-deletions if the deletions are normal.
So in this case, just a question. Suppose the spouse, the husband, is having a normal CBC pattern with a normal HPLC. The A2 is 2.8. So would you still go for molecular testing, or you would just leave it as such?
No, because see, in this situation, because one partner is a confirmed, so probably, I would give them the option of molecular testing, but generally I would assure them that, this he is unlikely to be a carrier. So, because we need a confirmatory answers many of the times in these situations. So, of course, the history will guide me that whether she had, these kind of presentation which is consistent with the alpha thalassemia. So,
Correct, right. So for the spouse, as recommended, we did a CBC and RBC pattern, and hemoglobin was 13 gram percent, MCV was 72, so microcytosis was noted, MCH was 22, so hypochromia also, and HPLC showed an HbA2 of 2.1%, which is maybe slightly reduced from the normal range. And so, Dr. Ishan, would you like to do any further workup for the husband?
So I think Dr. Seema ma'am has already answered. In this case, basically we are seeing that husband is having low normal hemoglobin and with a hypochromia and microcytosis, and HPLC showing a low HbA2 level. So it all indicates that maybe there is a possibility of an alpha thalassemia deletion. So hence, yes, definitely we would want to work up. And again, if we can do it sequentially to save cost. Like we can start with doing the testing for the deletion by means of MLPA. And if it is normal, then we can go and do the sequencing. Or if they come very advanced in pregnancy, we have to do everything together to give the answer as soon as possible.
Right. So most cases come after 20 weeks, right, Dr. Ishan? So we have to do actually a lot of things together. So in this case, alpha MLPA was done for the husband, and as we can see, a lot of probes lie in the range of 0.5 ratio. So that means these all probes, this region is heterozygously deleted. And when we analyze this case, we saw that the husband was Southeast Asian 2 gene deleted in one allele, and the other allele was normal. So again, the husband is having 2 gene deletion, and the alpha sequencing was also done to look if any point mutation is present in the other allele, but it was negative. Now, Dr. Ishan, is there a role testing in this case? Of course it is. So what could be the possibilities in the fetus, if you can explain the audience?
So yes, basically we have done the genotyping of both the husband and the wife. And if you look at the wife's genotype, we can see that there is a double deletion on one allele and a single deletion on the other allele. Whereas in the husband is having a double deletion on one allele and normal set of alpha globin genes on the other allele. So it shows that when husband and wife both are having double deletions on one allele, there is a risk of hydrops fetalis and HB Bart disease for this particular patient. Whereas if we take another case where there is a trans deletion, that means on either allele there is only one deletion. Okay, in such cases, they generally don't have a risk of having hydrops fetalis. The risk of hydrops fetalis only develops when the partners have got double deletions. Each of the partner have got double deletion on the one allele. So if you look at the possible fetal genotypes, when if this couple were to have a child, then the first possibility is the presence of double deletions on both the alleles in the fetus, which will lead to, of course, hydrops fetalis, and which is usually lethal. If let's say the fetus inherited a double deletion from the father or from the husband and a single deletion allele from the mother, in such case, the fetus would have HbH disease because there is a presence of a single alpha globin gene. If the fetus inherits the normal allele from the husband and the double deleted allele from the mother, in that case, the fetus would be expected to be an alpha thalassemia trait, which would be just a very mild anemia or mostly asymptomatic. And finally, the final combination is that if fetus inherits the normal alpha allele from the husband and a single deleted alpha allele from the mother, then in such case, the fetus would be a silent carrier. So we would say that when the fetus is either alpha thalassemia trait or a silent carrier, then we can reassure the family about the prognosis and probably counsel them about the continuation. But in cases of HBH and HB Bart disease, we would have to then counsel the family accordingly based on the phenotype that the child is expected to develop.
So basically, in such cases, there'll be 25% chance risk that the child can can develop hydrops fetalis, and this risk is present in every pregnancy, not just the first pregnancy or the second. So 25% chance in every pregnancy. So, Dr. Ishan, how do we do invasive fetal testing, and how would you like to proceed in such cases?
So for once we have had the molecular genotype of both the husband and the wife, then we can proceed to do molecular testing in the fetus. So generally, this testing is for every genetic disorder where a molecular diagnosis is established. So generally, we can do a chorionic villus sampling at around 11 to 13 weeks of gestation. And it is preferred because it allows early diagnosis, and we can counsel the family for the early reproductive decisions. But if they have missed that window, then probably the next window is the amniocentesis, which can be performed after 16 weeks of gestation. Cordocentesis for diagnosis is rarely performed because it is a very complicated procedure having much higher complication rates than either chorionic villus or amniocentesis. But like ma'am explained, that if during intrauterine transfusion, if you want to remove the blood for testing, that can be done, but it is not done for diagnosis as such.
Right. So the lab testing on the fetal sample, we had done targeted alpha MLPA for the alpha globin deletions. We don't need to do sequencing in this case because already none of the parents are having any point mutation in the alpha gene. So only alpha globin MLPA was done for this. And early molecular confirmation through CVS with targeted mutation analysis is the preferred strategy in high-risk alpha thalassemia pregnancies. So, Dr. Seema, is there a role of ultrasound surveillance apart from molecular testing?
Yeah, so just in case, like if you have already done the molecular confirmation that the fetus is not having the hemoglobin parts, then just in case the lab error, probably here in this particular case, we would like to do the sequential scans. Like this scan is the standard of care these days. Like one is at 11 to 14 weeks, then the second one is 19 to 20 weeks, then subsequently in the third trimester. So probably we will keep as a the people, those who know the molecular the fallacies, and also probably they will be vigilant about all these findings, like in the second trimester the findings of hydrops like edema, ascites, pericardial effusion, placentomegaly, cardiomegaly, then the MCA PSV. If there is a hydrops, then that will patient with alpha thalassemia can have other causes of eye drops as well. So probably, we need to check this anemia in them. So if molecular diagnosis is confirmed, then probably we don't require that much surveillance. But yes, one has to be proactive in, detecting in case.
Correct, ma'am. So ultrasound plus MCA Doppler surveillance complements the molecular prenatal diagnosis and helps detect evolving fetal anemia and hydrops early in at-risk pregnancies, or in case the molecular has missed, or can be more vigilant while doing the molecular testing. So again, Dr. Seema, key points on genetic counseling and management in such cases. How do you counsel the patients?
So as this is an autosomal recessive disease, so the risk of recurrence will be 25%, and there will be different possibilities, like the fetus can be silent carrier, fetus can be alpha thalassemia trait, or there can be hemoglobin H disease or hydrops fetalis, which are clinically relevant. Silent carrier and trait, they are not relevant clinically, so they can be assured, and the risk will be there in the every pregnancy. And of course, the extended family screening is a must. So whenever we come across like these families and we detect like hydrops fetalis in our setup, generally most of them would go for termination only, Very few, if they want, probably the intrauterine transfusion, because done at good centers, like the video I showed was at the our Rainbow unit, so where they are doing lots of intrauterine transfusion for other things, mainly the RH isomerization. So probably, this technique of the intrauterine transfusion is available at good centers. So if somebody wants to continue, then in utero transfusions, and they start as early as 23-24 weeks, and then delivery at term, and followed by the a postnatal transfusion like thalassemia. Here, the postnatal transfusion will not begin after 4-5 months of the child, but probably from the very beginning only. So, unless they want to continue, otherwise, majority, Ekta, we would suggest them to go for termination only. Nobody wants these kind of hassles in their life. So
Correct.
that will be the most practical advice.
Yes. So in this case, we did a prenatal diagnosis, and the fetal sample showed all 4 alpha genes deleted, 2 alpha gene from the mother and 2 alpha gene deleted from the father. So, and it was consistent with hydrops fetalis. Now, how do you proceed in such situation, madam?
Yeah, so as we just discussed, that unless she is very keen to continue, because this is a bad obstetric history, she has no child alive. Otherwise, I would suggest termination only. But if she really wants, then, and of course the MTP Act, if it is beyond 24 weeks, then we can't help much. So generally it is the di- directly suggesting termination based on the unfavorable outcomes and the lifelong hassle burden to the child and the family. But in case they want to, then the intrauterine transfusion is the other modality of the choice for the treatment.
So let's twist the case a little. Let's suppose the fetal sample actually inherited 3 alpha gene deletion, 2 from the father and 1 from the mother. So must be the HBH disease now. So how would you proceed in such a case? Genetic counseling. Explain, how do you explain the risk to the risk associated to the fetus, and is termination an option in such a case?
Like mother also has got hemoglobin H disease, right? And generally in alpha thalassemia, there is a good genotype phenotype correlation. Like if it is a 3 gene deletion, then so mother also has the similar, the range of anemia can be mild to the asymptomatic also. So we can give them, if in case they want, they can continue the pregnancy. This is not a condition of a straightforward suggesting the termination. And particularly we also see the background, how precious is this baby to them. So probably they can continue. And of course the option of the frequent monitoring by the ultrasound by the MCA Doppler to check any fetal anemia. And then postnatally also the child should be under the care of a hematologist at a tertiary center, so that the anemia is taken good care of. And so all these, they have to be informed that, of course, thankfully this mother didn't have all these issues, but for this baby we can give them all these possibilities can happen, asymptomatic to the requirement of transfusion, infrequent though, but all these should be discussed, and they need to take a call that yes. And if it is within the MTP Act, that is less than 20 weeks or less than 24 weeks, they have this option available with them.
Okay. Dr. Shaji, would you like to add some comments on this? Like what is your opinion on this?
Yeah, this is a common situation. No, I think I confused this with the BARTs, but do you see a fetus with HBH? This was an antenatal diagnosis then, correct?
Yes, sir.
This was an antenatal diagnosis. So now if you look at the clinical history of HBH disease, we see a lot of adults with HBH disease also. So explaining to the family, saying that, we need to do a lot of counseling to talk to the family and, convince them anything is required to do for termination. And I will find it very difficult to convince them, because we have seen a lot of patients from West Bengal who have crossed the teenage, have HBH disease, and milder than thalassemia major or homozygous sickle cell disease. And I would find it very difficult to convince the family.
Yeah,
Do
we can
you?
take a look from the mother's, health condition, that
Yeah.
because she's so, and we also need to see this is a very personal decision. Termination is not, we can give them the facts and figures, like we can give the example of the mother who has still now had never received transfusion. And the literature also says the asymptomatic to, severe. So all these uncertainties also need to be discussed, and probably that should be their call rather than we should be suggesting termination.
I agree. We need to do a lot of counseling.
Yeah.
It's not going to be easy one. Yes.
So the key message here is accurate molecular diagnosis, early prenatal testing, and comprehensive genetic counseling are central to managing the high-risk alpha thalassemia pregnancies. Now we come to second case. She's a 48-year-old female presenting with weakness, fatigue, pallor, icterus, and splenomegaly. However, there is no history of blood transfusion. Microcytic hypochromic anemia with evidence of hemolysis on the biochemical reports. Was referred to the hematologist. Investigations were done. Again, a significant finding on hemoglobin HPLC was noted. So this is the HPLC where we see A2 of 1.8%. Again, a 2.5 to 3.5% is the usual range of A2. 1.8%, I would say it's reduced. There is a very minor peak of 1.8% in the C window. If you see the C window here, so this is the peak in the C window, which is a cluster of 3 peaks if we can see properly. And there is something in the early integration peak also. We can see something may or may not be, but we are not very sure. So Dr. Ishan, what would you suspect in such a case?
So if we look at the total picture, right, from the history, some clinical findings, then the CBC, and finally the HPLC. And when you put the dots together, for example, in this case, this lady had features or history symptoms which were suggestive of anemia, and then on examination there was a splenomegaly, and there was on CBC we could see a microcytic hypochromic anemia and with some evidence of hemolysis. And finally, when the HPLC was done, it showed a very low HbA2 level as well as 2 peaks which appear to be suspicious. So all in all, there is a strong chance of alpha thalassemia first. Secondly, the abnormal peaks can point us to a direction of an abnormal hemoglobinopathy, which might, abnormal hemoglobin variant, which might have been eluted in the HPLC. So we would have to probably look at connect with the lab to discuss, what are the various hemoglobins that can be eluted in C window, as well as the early peak. There is also some suspicion. So as I said before, that there can be HBH also that can be eluted so early, but labs have to take that extra step to actually read. Many of the times, if in the routine things, labs may miss reporting this very early peak, because just as a false, just as an injection or a void integration or something like that. So
Sure. Can I add
so
something?
yes, sir, definitely.
Sorry. So,
Yes, sir.
Ekta, if I would suspect HB coadora in this case, which is highly likely, especially if this patient is from Andhra. So we have seen cases like that.
Right, sir. Right, sir. So this is actually a hemoglobin coadora. I would have come to that later.
Yeah.
Oh,
But,
sorry.
Yeah, this is that.
no problem, sir. Just to show you that this was actually reported from outside, and this minor peak of 1.8% in the C window was overlooked by the reporting pathologist, and a reduced A2 level also was just implicated to maybe an iron deficiency anemia. So it was actually reported as normal. So when it came to us, we did a thorough investigation and a molecular diagnosis, and then we came to the diagnosis actually. So Dr. Seema, what should be the first line molecular strategy considering the HPLC and all the hemoglobin patterns that we have seen? So how would you proceed with the molecular strategy in this case?
Yeah, so in this case, like for alpha thalassemia, generally we would do the deletion only, deletion studies only. But yes, in this case, probably we are more suspecting of the this variety. So the we even the NGS first would be also work. I hope so. So what was alpha? Yes, so deletion was first done, right? And it will be only identified on the alpha sequencing only. So probably, do you think Ekta that seeing the HPLC, the alpha MLPA was not the right choice first? It was mainly the sequencing.
So, ma'am, we should have done sequencing, and we had done sequencing only in this case. So,
Yeah,
whenever it is homozygous point mutation, it is
yeah,
very important that we also do alpha MLPA because the other allele might have been deleted. So, if the other allele is deleted, we will see homozygosity in the Sanger sequencing. So, to
okay.
confirm the exact genotype, it is important that whenever we see homozygosity, we do an alpha MLPA as well. So, in this case, we saw homozygous Coyadora, and so we did an alpha MLPA. MLPA was negative. So,
That was the second step, right?
that was done a second step. And
Okay.
so, diagnosis of homozygous hemoglobin Coyadora was given. So, whenever there is homozygous point mutation, especially when it is in the HbA2 gene, it can result in HbH-like disease. HbA1 homozygosity may or may not result in HbH, but HbA2 homozygosity usually results in HbH-like disease. So,
And
this
just
was
because of two genes only, here there is no three genes, right? So point
no,
mutations are only, yeah,
yes.
on
Actually,
deletion, they are more severe, right?
Mostly because if we know that alpha HbA2 is responsible for more than 70% of the alpha globin gene production, alpha globin chain production. So if
Yeah.
A2 is hampered, then almost 70% of the alpha globin chains are not produced. So only 30% remaining. So again, the imbalance is there.
Okay.
And the Sanger
By
sequencing
two
showed,
genes also. This is
yes,
hemoglobin H
HLP
only. Yeah.
mutation. Yes, two
Yeah.
gene mutation. Yes,
Two
ma'am.
gene. Because contrary to the normal, of
Three gene
yeah,
concept.
three, it's a two only. Yeah, good, good.
Correct, ma'am. So, so this Sanger sequencing chromatogram looks like this, something like this. And here we can see the reference was A, but in the patient, we saw that the A has been substituted by C. So, homozygous point mutation here. This hemoglobin Coyadora is an anti-termination and frame shift mutation. It results in a point mutation at the termination codon. So, where the gene should have been terminated, which is at the codon 142, there is a point mutation from A to C, which results in anti-termination. So the protein do not terminate there. Instead, there is an elongation of the protein by around 31 amino acids, and this elongated protein is very unstable. So it rapidly degrades, and that is the reason why we see such small peak of only 1.8% on the HPLC, because it doesn't remain much. It's rapidly degrades itself.
Okay. Yeah.
So, ma'am, how reliable is HPLC in identifying rare alpha globin gene variants?
Uh, you know, practically, one has to be vigilant, as in discussed in this case, if it was not picked up earlier. So they because the peaks could be subtle or overlapping, and so retention time which mimic the other hemoglobin variants. So generally, one has to again keep a high index of suspicion. Then only you can find out, suspect on the HPLC, and then followed by molecular testing, or even the hemoglobin H inclusion studies can be done to increase the suspicion. So it can be missed easily, I feel, if you are not
Yes. What
yeah.
happens is whenever deletion is there, there is no abnormal hemoglobin peak in the HPLC. So when we see if there is alpha globin deletions, the only points pointing towards alpha thalassemia would be a little decreased A2 value and MCV and MCH reduced. But whenever, in most cases, 90% of the cases, if there is a rare unknown point mutation hemoglobins, the ones which are caused by point mutations in the alpha globin genes, they will produce some unknown peak in the HPLC. So, looking at the HPLC and reading the graphs properly is very, very important. So, most cases, we will see an abnormal peak in the alpha globin variants.
Yeah, we keep getting in HPLC these kind, but Coyadora I have never come across. Probably in northern part this is not, we
Mm.
see Geo Toronto, Meerut only
So,
here.
Koyatara was actually first originated in Andhra, as sir has already said. But
Mm.
I have published a case report of 4 cases, and all those
Okay.
4 cases are from East. 3 are from Northeast and 1 is from Odisha. So it's not like that they are only present in Andhra. Now they are present, I mean, almost everywhere.
Yeah, it's just the awareness increasing.
Yes, ma'am. So HPLC can raise suspicion for a rare alpha globin variant, but definitive identification again requires a molecular characterization. So for Dr. Ishan, how do deletional and non-deletional alpha thalassemia differ clinically?
So, as we have seen that basically deletional type of alpha thalassemia leads to a quantitative reduction of the alpha chains as compared to the beta. So that will lead to the overall phenotype. Okay, so there is, in a way, there is no change in the quality of the alpha globin. Whereas on the other hand, the non-deletional, they are the hemoglobinopathies, which are changing. There is some structural change in the hemoglobin as well. So this leads to the hemoglobin alpha globin protein becoming a little unstable. So then it is causing ineffective erythropoiesis and hemolysis along with just the quantitative decrease. So they tend to be a little more severe as compared to the deletional ones.
Yeah, right. So that is what, and again, the the 70% thing, that is also very important. And now, can hemoglobin coadora mimic other hemoglobinopathies on HPLC? So yeah, the retention time, if you see, is around 4.96 seconds. So whenever we look at the HPLC, some very important things to notice is the retention time and the percent hemoglobin. So not everything that elutes in C window is HBC. Not everything that elutes in the E window is HBE. So it is very important that we look at the retention time and the percentage hemoglobin that it is eluting. So for the coadora, it elutes in the C window with 4.96 retention time seconds, and the percent hemoglobin will be very small, 0.5 to 2 to 3% maybe, because it is highly unstable. And if you see the morphology of the peak, there is one big peak followed by a pre-peak and an after peak. Those a cluster of 3 peaks are seen. So, and these why it mimics with other hemoglobinopathies is a lot of other mutations which occurs in the termination codon of the HbA2 gene can show a peak in the HBC window, just like hemoglobin coadora. So, molecular approach is a must for confirmation. The same constant spring, which we know hemoglobin constant spring, this is also a termination codon variant, and this also elutes in the C window, similar to coadora. But in Indian population, constant spring is not very uncommon. So in Indian population, if we see such peak, we should suspect hemoglobin coadora. This is okay. So this is another hemoglobin electrophoresis picture of the hemoglobin coadora. If you see, there is a HbA2 of 1.5%, and there is a small peak of 1.5% in the hemoglobin constant spring CS zone. So HbCS zone is the one which is in the coadora elutes in HbCS zone in the electrophoresis, while it elutes in the HbC window in the HPLC. So there are other anti-termination mutations, just for your knowledge: hemoglobin seal rock, Icaria, constant spring, Kinsasa, coadora, Parkse. So these all are the anti-termination mutations. So Dr. Ishan, are rare alpha globin variants underdiagnosed in India? What do you feel?
Yes, so alpha thalassemia in general, so in fact, I would say whenever we talk about thalassemia, the default understanding is about, we think about beta thalassemia because it is much more prevalent, there is much more awareness about it. But there is also an equally important type of thalassemia, which is the alpha thalassemia, which I think, webinars like us should be made more often so that people also understand that there is also another category of thalassemias which need discussion, which need awareness, and which need proper testing, because the testing of alpha thalassemia is quite different from beta thalassemia. So people might be knowing about beta thalassemia testing, but they don't have knowledge about the alpha thalassemia, how they present, what would be the CBC and the HPLC picture to suspect alpha thalassemia, and what molecular tests are to be ordered in a case of suspected alpha thalassemia. So combination of all these factors, just the lack of awareness, the lack of understanding of HPLC interpretation when it comes to alpha thalassemia, as well as the availability of maybe the molecular diagnostics. Not every lab may be conversant. All this overall contributes to a little less underdiagnosed alpha thalassemia as compared to beta in India.
Correct. So similarly, I had already mentioned we had 4 cases in our lab in Unipath lab, and our department, published a paper in IGHBT 2 years back. And these all, as mentioned, all of the 4 cases mentioned here were not from the south. All the 4 were from the northeast and the east. So rare alpha globin variants are probably more prevalent than currently recognized in India, and increased awareness with integrated molecular testing is essential to improve diagnosis. So, Dr. Seema, do you routinely include alpha globin sequencing in unresolved microcytosis cases?
Generally, I don't work up much for microcytosis. I work up more for the hydrops fetalis. So yes, whenever I feel that this was a anemia type of hydrops fetalis, then yes, and then I go back retrospectively, like that the CBC and then HPLC, and then so not that microcytosis, but yes, with now with new awareness, probably I'll be more vigilant about the A2 and the F, and then all these C window, and so that I can pick up more cases. But till now, I was mainly focusing, because from the obstetric background, it is mainly the hydrops which comes to our mind. So not the microcytosis, because they go more to the hematologist.
Right. So, case to wrap up, rare alpha globin variants can present as subtle hematological abnormalities. HPLC alone may not provide a definitive diagnosis, but definitely it can give us a clue. Molecular characterization is essential, and integrated interpretation between clinician, hematologist, molecular lab is critical. So, with this, okay. Just one more question, Dr. Seema, Dr. Ishan, any one of you, pitfalls of alpha thalassemia diagnosis on NGS. So your comments on this?
Yeah, because NGS will not pick up the deletions, and large deletions mainly, because these days they do say that the CNV pipeline they do have, so but probably these MLP, the alpha globin gene deletions will not be picked up. So
Correct, ma'am.
this is
So a
mainly for
lot
the
of
point mutations only.
So alpha HbA1 and HbA2, they have got very similar sequence homology. So whenever the sequencing occurs and the software has to map those reads, the software is unable to correctly map whether this read has originated from HbA1 or whether this read has originated from HbA2. Now this is the major problem which the software faces, and because of that there is something called as multi-mapping of reads, misalignment, and this kind of picture basically skews the entire picture for diagnosing deletions or duplications by means of NGS, because in NGS it is only the software that gives a call that maybe there is a deletion or a duplication sitting over there. But because of this high homology, so this particular shortfall of NGS is not only for alpha thalassemia, it is for any gene which has got high sequence homology. So
like
even if there is a gene which has a pseudogene, and the gene and the pseudogene have got very high sequence homology, still NGS can have problems in correctly mapping the reads, whether they are originated from the actual real gene or from the pseudogene. So NGS should not be used for deletion duplications. We should use MLPA
this is the key
or
point that
gap PCR.
Yes, NGS should not be used for alpha CNVs, because it is very difficult. In fact, a lot of labs might promise you that we are looking at all the CNVs. Yes, they might be looking at other CNVs, but alpha CNVs is very, very easy to be overlooked and missed in the NGS. But apart from deletions, let me tell you that because of the high homology between alpha 1 and alpha 2 genes, even I have seen 3 or 4 cases where the point mutations are also misread. A single point mutation they have given in A1 also and in A2 also. But it cannot happen in both the genes, that we know, right? So we had to do Sanger sequencing to exactly know which gene was having the mutation. So even in point mutation, the misalignment can lead to false positives. So ultimately, I always suggest that for alpha Sanger sequencing and alpha MLPA is above NGS. So just one last thing. This is hemoglobin sun prairie. This is the hemoglobin electrophoresis run in the Sabia instrument. HbA was 97.5%, A2 was 2.5%. Patient was presenting like hemolytic anemia, but the HPLC pattern was absolutely normal. There is no abnormal peak. There is no reduction in A2. However, we saw an HbA2 variant, homozygous HbA2 variant, which is called homozygous hemoglobin sun prairie. So now to let you know that there are some hemoglobins in alpha variants, which eludes within the HbA window. So you might completely miss it, and no one can actually pick up on HPLC or any other way. So this patient actually did a whole hemolytic workup, and everything was negative, including the HPLC, the EMA study, the osmotic fragility study. Everything was negative. Ultimately, he had to go for NGS. And in this, the whole exome sequencing actually picked up this variant. And when it picked up in both A1 and A2. And then we did an alpha sequencing, Sanger sequencing, to know which gene was mutated. And then we saw that HbA2 had an homozygous point mutation. So
Yeah,
alpha
so
is
that gives us an insight that because NGS is easily available, so we also had a case like, in the alpha thalassemia, where the NGS was just started, and then that picked up the point mutation. And in the X-linked mental retardation, the same ATRX, after I
ATRX.
published my paper. So I have started feeling that, of course, the NGS we cannot detect, but at least that will give us some, further
Correct.
clue to work up further.
Yes,
So,
yes.
yeah. So, one thing which I
Alpha.
wanted to ask you, Dr. Ekta, how do you decipher whether it is cis or whether it is trans?
So, ma'am, on NGS, we cannot do unless
No,
they
not
are
NGS. I'm talking about the
Sanger.
minus. Yeah, the deletion only, MLP only.
Uh-huh. So, ma'am, the deletions, if we have two alpha 3.7 deletions, if we have an homozygous alpha 3.7 deletion, it has to be in trans only.
Okay.
3.7, alpha 3.7 or alpha 4.2 cannot happen in cis because it deletes a part of A1 and a part of A2. So it
Okay.
cannot happen in one allele. It has to happen in both the alleles.
And what about the SEA, the minus minus? How do
Yes.
you?
So SEA is a large deletion. It encompasses a deletion of A1 and A2, both in one
Mhm.
allele. So it has to be in cis only. It cannot be in trans.
Okay. Okay. So you don't need the parental testing to decipher that
No,
whether it
no,
is.
ma'am. In most cases, we don't need this.
Oh, okay. So by
So
the
for
pattern of
SCA, it
deletion.
is cis. It is understood to be cis, and for
Hmm.
just 3.2 or 4, either it has to be in trans.
Yes, if it is homozygous, it
2.7.
has to be in
It
trans
is
only. It cannot
homozygous,
be in
yes.
cis. Yes.
Okay, so if they are in homozygous, and if they're heterozygous, it's not a problem.
Yes, heterozygous not a problem.
Mhm.
So we end up with this, and is there any question and answers we'll take up now? Thank you so much, madam. Thank you so much, Dr. Ishan.
Thank you. Thank you. Well
Thank
done.
you. Thank you. I think we
Thank
can
you to our
request Shaji sir to
yes,
give his
Some
insights, sir.
some comments.
Dr.
Yeah,
Shaji sir requesting for
thank
you.
you. It was very, very interesting session, and I learned a lot. And
Sir,
we
I
are
learned
also
from you.
that's your modesty, Ekta. Okay, thanks a lot, Ekta, for coordinating this Q&A also, and the panel discussion was excellent. There are three, one or two questions there. Would you like to take it up, Ekta?
Yes, sir, sure, sir.
Yes, so the first question is how do we differentiate delta thalassemia from alpha thalassemia by an HPLC test?
So in HPLC, A2 will be reduced in delta as well as alpha thalassemia. What I have seen only 3 cases of delta thalassemia till date, and in all the 3 cases, the A2 was severely decreased. It was less than 1%. Along with that, there was no clinically the patient had no phenotype. It was incidental detection. In all the 3 cases, they were incidentally detected. So delta thalassemia will not produce any symptom. It will not be they will not come with any thalassemia like picture, and A2 is usually very severely decreased.
F may be high. F
Yeah.
may be high.
one more thing, if delta beta deletion is there, then you will have, beta.
Different.
The
So delta
HbS can
beta
be
deletion is a different story
it's a
altogether.
different story.
Come here. Dr. Shaji, do you want to add on this delta and alpha?
Yeah, I think you know that we had a publication on this that yeah. So when you look at the hemoglobin A2 levels to see probable alpha thalassemia inheritance, we would overlook this delta thalassemias. So we had done studies like that in cases where we did not see alpha thalassemia. We found 2 or 3 cases with mutations in delta thalassemia. But fortunately, those patients do not show symptoms as severe as alpha thalassemia shows. Just based on HPLC, we just jump into it. But based on the phenotype, it is not a big deal.
Okay.
Thank you. Should I move on to the next question?
Yeah, Dr. Monica.
Sure. So it's with respect to the case one, the question was, what if the husband has a silent mutation? I think this was discussed already, but if you would like to throw some more light.
The husband actually had 2 alpha gene deletion in the first case. So the husband was asymptomatic, but had 2 alpha gene deletion. The mother had 3 alpha gene deletion. So we had to do a prenatal diagnosis in this case. And as seen here, the fetus was actually Hydrops fetalis.
Right.
I don't see anything. Anyone has any input?
Yeah, please.
Yeah, I just wanted to add one thing I think we have all had different perspectives. One hematopathology perspective is that, whenever you're approaching the thalassemias, this Ekta highlighted that HbH preparation is very, very relevant whenever we are approaching, and it is a very cheap test to give you a sense that whether this is a 2 gene or a 3 gene deletion is there. So when I am strongly suspecting that having an HbH preparation and a golf ball gives me a lot of confidence that I need to look for deletion, I need to look for point mutation, even if I'm getting one thing or the other thing. So that way, and as ma'am was mentioning and highlighted, Ekta, like 2 gene HbH on golf ball, you may need to look that HbH preparation a little more carefully, because since this is quantitative, so you may not have a lot of HbH everywhere. So it might be very few, golf ball, but you need to look it very carefully on that HbH. And it can be easily missed if it is 2 gene kind of a thing. 3 gene, yes, a lot of golf ball is there and you are able to pick up that. And this gives you confidence that, okay, I'm dealing with an HbH. And then now I need to work up genomically. So I do an MLPA or sequencing, whichever way, because we are thinking in one straight way, like CBC, HPLC, genomics, and everything. The things may not be as straightforward because patient can come in any way. There might be only sequencing done, there might be only MLPA done, So that way, having an HbH preparation is very helpful in approaching that. So that was just one thing that I wanted to add.
I can see one question by Dr. Ruchi Gupta, that even when the parents are asymptomatic, but HPLC also shows normal HbA2 values, but both can have 2 gene deletion with asymptomatic and normal HbA2 value, which is absolutely correct. So in such cases, it is very difficult that should we go for alpha thal screening in all the cases who come to a fetal medicine doctor, or how do we filter out whom to screen for alpha thalassemia and whom not to screen for alpha thalassemia? So one point, according to me, is to look at MCV and MCH. So microcytosis and hypochromia is a very important thing to look at when you want to rule out alpha thalassemia, because a lot of cases can have 2 gene deletion but normal A2 values. So in those cases, we will miss out all the alpha thal cases. Dr. Seema, do you have any input in
Yeah,
this?
the same thing that, like, we have to keep on watching the microcytosis, whether it is due to iron deficiency or whether it is due to the alpha thalassemia or delta beta trait. So all these has to be excluded whenever we see. So not routine as a I don't think that we should be as a routine doing alpha globin, screening for everyone unless there is a microcytosis. So
Yes.
without that, and microcytosis both partner probably, or maybe a single partner, so maybe. So unless there is a microcytosis, I would not work up, or unless there is a history of recurrent hydrops like situations where I would like to look into the CBC. And
Moving on, there's one more question. How does one detect delta beta thalassemia on genetic tests? Question mark. Methods. On HPLC, can we only give provisional delta beta heterozygous or HPFH het? That's a question.
So for delta beta and HPFH, we have to look at the F values. In delta beta thalassemia, the F values will be around 15 to 20%, and anything between 22 to 35% can be HPFH. So these are heterozygosity for delta beta and HPFH. So in those cases, we have to look out for F. So it is not at all confusing between alpha thalassemia and the delta. They are not mimickers. So, and for molecular diagnosis, we have to go for beta MLPA. Just like we have talked about alpha MLPA that look for large deletions in the alpha globin cluster. Similarly, we have a beta MLPA which look at the large deletions in the beta globin gene cluster. Both delta beta and HPFH are large deletions. They are not point mutations. So large deletions needs to be screened by the MLPA technique.
Also, in
Thank
most
you.
cases of delta beta thalassemia and HPFH, CBC values also will be helpful.
yeah,
Yes.
microcytosis will be.
Microcytosis.
Thank you. Another question more relevant to prenatal setups. If the mother is an alpha thal carrier confirmed by molecular test and the partner's HPLC is normal, should we still go ahead and do the molecular testing for the husband?
Yeah, so, like, of course, if there is microcytosis, yes, it's very, very essential. But if there is no microcytosis, I'll be little, not very keen to do. But alpha thalassemia testing can be, if there is a history, like some history suggestive of the situation which we discussed, like hydrops fetalis, hepatosplenomegaly. In those situations, I would like to go with the molecular testing. Otherwise, without microcytosis, I would not like to do the molecular tests. Yeah,
Thank you, ma'am.
microcytosis and any HPLC suspicion like which they showed. So maybe I would like to discuss with the hematologist again that are you very sure of these peaks and all. So probably I would not be very doing much.
Sure, ma'am. There's a
Because
message in
pregnancy is a
the
very sensitive point. So, you just can't, create lots of, fear in the patient's mind that, unnecessarily, because unless there is some suspicion, then of course, yes. But otherwise, we don't want to do that much because alpha thalassemia is not that common. Unless there is some history, then probably, yes, I would go ahead.
Sure, ma'am. Any other remark?
Yeah.
Yeah. So there's a message in the chat box. Nice discussion. I am from periphery of East Bihar and getting many cases of HbA2 level between 1 to 1.5 or even less than that. He's asked Dr. Ekta to share her contacts so that he can further discuss cases with Dr. Ekta. So some more messages on congratulating the entire team for an informative talk and discussion. Any closing remarks, Dr. Neeraj sir and Dr. Shaji sir?
Yeah, I have already shared that this has been an excellent session, and we have all learned from Shaji sir. Thank you, sir, for joining at the last moment. So this was and to having an expert sitting with us and guiding us, it is really helpful. And thank you so much, ma'am, for sparing time for this webinar. I know these rare kind of awareness campaigns help us, get better diagnostic things in place. And
But,
thank you.
I couldn't get experts on such a short notice when we decided that we need experts, and I couldn't manage. But because it is CMC, so probably you could get that. But in our part, I couldn't manage to get anyone who can, come for the last 1 day notice that you just come and be a chairperson, because this is a complex topic. So
Yeah,
probably unless you are doing it, you have diagnosed earlier, it will be difficult. So so we need probably more such meetings.
Yes, ma'am. And Ekta has been, very, very nice covering I think almost everything in this session, guiding in, rare variants. Very nice. Thank you, Ekta. And thank you, Dr. Ishan. Very comprehensively, you have touched upon areas where, rare variants very nicely you have touched on. So thank you. It has overall been quite learning experience for all of us. And, this side of awareness in the right way with the right people help a lot of people. That's what I believe. So thank you everyone from my end, and we look forward to connect again from further insightful talks. Thank you everyone.
Thank you, sir.
Thank you, everyone.
Thank you, sir.
Bye everyone.
Bye everyone. Bye.
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 So heartfelt thank you to Shaji sir, Dr. Neeraj sir, Seema ma'am, Dr. Ishan sir, Dr. Ekta ma'am.
And I also should thank Dr. Monica as well. I forgot to thank
Yeah, Dr.
for
Monica,
arranging everything. This has been extensively and very well done. Thank you so much.
Yeah,
Thank you,
she
sir.
organized
Thank
it
you.
very
And
well.
especially, I think we must thank the audience for
Yeah.
a patient
Yes.
hearing at the late evening and contributing to this wonderful discussion. So, looking forward to more such sessions along with the genetic clinic. And again, this entire recording will be available by 20th of April on Unipath's YouTube channel. So the entire attendees can go and revisit the entire talk. I think this should be revisited again and again to get reference to some of the context points. So that's what can be done easily through the YouTube channel. And you can subscribe to the YouTube channel as well. So thank you so much for the patient hearing. Thank you, everyone. Have a great evening ahead.
Thank you.
Thank
Bye.
Thank you, sir. Thank you, ma'am.
Thank
Thank
you.
you. Bye bye. Take care.
Thank you.
Thank
Good night.
you. Thank you.
Thank you.